So remember that the major source of blood is coming from the bronchial artery. The bronchial circulation is extremely complex. Okay, so it is very heterogeneous where the bronchial arteries come from in the normal population. So A basically up here shows the most common variations of the origin of the bronchial vessels. So you have one large vessel that comes directly from the upper rim of the descending aorta feeding the right side, and two that feed the left bronchial tree. This is the most common, and it's only in 40% of people. Other variations are 20%, basically from the same origin, but different, arteries. Sometimes you'll have one artery, sometimes you will have two arteries, sometimes you have three arteries feeding the bronchial tree. Many other known variations, but they are extremely rare. This is very important when you are, doing the arterial embolization. It's more, important for the interventional radiologist to know this, but we also should know it because here soon, hopefully, we'll be able to do something with even endobronchially for the bronchial arteries. Okay, so there are some people thinking of doing endobronchial approaches to stop bronchial bleeding by doing, just injections through the airway. This is the anatomy. You need to know it, of course. This is the expected location of where the bronchial vessels are. These are exaggerated bronchial vessels just to show you, these are not normal. These are ectatic, dilated bronchial vessels, but just to show you where would you expect to find the bronchial vessels from their, origin right here in the descending aorta. This is a bronchial, basically vessel right next to the bronchus on CTA. And this is a cadaveric view of the bronchial vessels. This is the descending aorta right here. And these are the bronchial vessels basically coming out, crossing. Okay. You have to understand that in diseases that cause lots of inflammation in the lung, okay, uh, arteriogenesis and neovascularization due to inflammation will actually attract, okay, sources of vessels that are outside of the normal structures. So people, especially who have tuberculosis and have mycetomas, okay, a big portion of them will have feeding arteries that are coming from intercostal arteries or from subclavian arteries or internal mammary gland arteries. Okay, so it's not always a bronchial artery that feeds them, even that they are intrapulmonary lesions. Rerouting happens. So, what is the importance of bronchial arteries? Why do they exist? Um, they exist because in when we have an obstruction of pulmonary arteries, for example, these bronchial vessels actually work as a shunt of the blood, okay, to feed the parenchyma. So in normal situation, you have bronchial capillaries and you have pulmonary capillaries that are basically separated from each other, right? The normal fraction of the shunt in our lungs is what? 1%, right? Bronchial vessels drain into basically, instead of draining into the superior inferior vena cava, they drain to the left side of the heart. That's about 1%. Okay. Now, in cases where you have, for example, obstruction of the pulmonary veins, obstruction of the pulmonary arteries, diseases of the pulmonary capillaries, what happens? Okay, these closed vascular structures that we have at birth, okay, actually open up. So you will have aortopulmonary collaterals, you will have arteriovenous collaterals and venovenous collaterals. These will happen whether you have bronchial vein occlusion or pulmonary artery occlusion or lobar vein occlusion. So these shunts will actually grow. And if the shunts grow, okay, you can have bronchial artery hypertrophy, bronchial vein hypertrophy. Okay. Why am I saying this? Because in diseases that affect the pulmonary artery, you have excess rates of what? Hemoptysis, like chronic PEs, fibrosing mediastinitis. This is the pathophysiology of why the veins and the arteries dilate in the submucosa. You have pulmonary varices, and these can bleed. Okay, so remember, it's not always the bronchial artery. It could be the bronchial vein. It could be anastomosis. Okay, this is a CT scan of how in someone who has fibrosing mediastinitis, you have a pulmonary varix there. You see it how big it is on the CT scan. Look how this worm. Look how ectatic this bronchial artery is in someone who has fibrosing mediastinitis. It got enlarged because it got engorged because the pulmonary arteries are basically constricted and the blood is trying to find its way around. So, just some general principles regarding how to deal with hemoptysis. I just want to say that hemodynamic instability, hypotension, okay, uh, collapse, okay, is extremely rare in hemoptysis unless the patient is about to code. Why do people die from hemoptysis? Asphyxia, right? So if you have hemodynamic instability, okay, most if the patient is talking to you, it's not the hemoptysis that is causing this. Look for other cause. Okay. Um, um, uh, so and always your thought should be basically to protect the airway and protect the ventilation. Okay. Always seek the most experienced person to intubate if you have a case of hemoptysis. Trust me, if someone has a massive hemoptysis, it is going to be very hard for you to see where the airway is. It will be very hard for you to see where the vocal cords are. It is not an easy job. Get the anesthesiologist with you. Get your partner with you if you're working by yourself. Get as much help as you can with you. Get the surgeons, okay? Because if someone is just exsanguinating blood out of his airway, be ready for what? Any sort of airway emergency. It is a top airway emergency. And the last thing and most important thing, always protect yourself. When you're dealing with massive hemoptysis, don't intubate without mask. N95 gowns. You don't know what's going on. Remember, one of the most common causes of severe massive hemoptysis is tuberculosis, mycetoma. Always be what? Safe. Okay? So how do we identify the severity of hemoptysis? And this will guide us on how we will manage the hemoptysis, right? A mild case of hemoptysis is not going to be managed the same as massive hemoptysis or very severe hemoptysis. For me, the literature is very murky about what massive hemoptysis is. Some people say it's 100 mLs an hour. Some people say 100 mLs in 24 hours. Some people say 600 mLs per 4 hours. There are lots of definitions depending on the study that was made. For me, um, 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 I base the severity of the hemoptysis based on the physiological consequences of the hemoptysis. Okay, massive hemoptysis is any hemoptysis that cause worsening hypoxic respiratory failure. Massive hemoptysis is any hemoptysis that can cause hypercapnic respiratory failure or worsening of it. Okay, anybody who has hemoptysis and respiratory distress is a massive hemoptysis, even if he coughed up 5 cc's. Okay. Any worsening in the intubated patient, like you have someone in the ICU, suddenly has worsening hypoxia, and you see a tinge of blood in the airway, this is massive hemoptysis. Deal with it as massive hemoptysis. Okay. During bronchoscopy, if you have bleeding and you fail to see the airway, it is massive hemoptysis. Deal with it as such. So as we said, asphyxia is why people die. Why is that? What's the dead space? How much dead space do we have?
Trachea and the
Yeah, what is the volume of the trachea? Do you guys know? 50 cc's. If someone is sedated, paralyzed, intubated, only 50 cc's of blood are enough to kill him or her. Okay, so we die from what? Asphyxia, occlusion, lack of ventilation. So how do we prevent that? Okay, the number one thing that you want to do, of course, is to establish an airway, guarantee ventilation. Don't think about what oxygen is. Concentrate on ventilating the patient. Okay, and a saturation of 50% does not mean shit. It will drop further if you do not get a ventilation. You need to get a hole in that clot and ventilate the patient. Giving more oxygen, higher FiO2, CPAP, just get the patient to ventilate, create an airway, then stop the bleeding. Okay, so number one for me is, intubate, okay? Sedation and paralysis if needed. Why do we say sedation and paralysis for patients who have life-threatening hemoptysis? Why? I mean, that sounds counterproductive. Why? A cough should help clear the airway. If there's a clot, if someone coughs, you will get it out. Why do we say that,
Sometimes this clot actually tamponade the area of the bleeding, so you don't want to, like, if you're able to manage the bleeding yourself, you don't want that patient to cup up that clot that is tamponading the area of bleeding, like be localized area.
But if it's not tamponading,
What it is,
if it's not tamponading the area, there's a clot just like in there, but it's not like helping to contract the area.
Gonna be some dilation.
This is the difference between massive and non-massive hemoptysis, right? Non-massive hemoptysis maintain the cough. In massive hemoptysis, you have to suppress the cough.
You don't want the
Why?
to go to the other
If you have a massive hemoptysis, right? You have an artery that is open, right? A big artery that is open into the airway, right? What happens when we cough?
Increase the
Inhale first.
Mhm.
Negative pressure here,
Mhm.
right? Negative pressure here. The negative pressure here that is in the airway, what would it cause?
would cause more suction.
Suck more blood in, right? Okay. Now, when we cough, okay, what will happen? Positive pressure here, positive pressure here, positive pressure on the airway, positive pressure here, positive intrathoracic pressure, right? But as we release our vocal cords, what's going to happen? Negative pressure here, suck more blood in. Okay. Now, why does this not happen with non-massive hemoptysis? It does happen, but this process, the flow that you create, will be able to clear the airway in non-massive hemoptysis. When we say it is massive hemoptysis, there's 100 mLs an hour going in. This process will exacerbate the blood. Okay, so this is why you need to sedate and paralyze, because you want to stop this cycle. In non-massive hemoptysis, this cycle is beneficial because it empties the airway. Okay, in massive hemoptysis, when you have massive hemoptysis, this is already occluded. There is no air here to push the clot. Remember, you need flow to carry the clot. If you have an atelectatic lung where the bleeding is coming, okay, there is no flow. Your cough is just basically acting as a suction mechanism. There's no flow to carry that clot. You're just adding blood to the clotted blood. Okay? All right. Number two, in cases, we're talking about someone who's dying from hemoptysis, right? We're not talking about someone who's just coughing blood on the floor, right? Second thing, okay, you don't have to have a chest x-ray, okay? You do not have to have a CT scan for massive hemoptysis, okay? You intubate, you immediately bronch, okay? Bag ventilation is probably the best, okay? Because you can feel what's going on with the lung. Am I getting air in or not? Okay, you can sense it. Okay, hooking someone on the ventilator while you are bronching, while he's having massive hemoptysis, might be deleterious. You will not know if the patient is getting ventilation or not because you're suctioning, you're inside the ET tube, high pressures, the machine is alarming. You don't know if the patient is getting tidal volume or not. Bag and feel that the patient is getting what in. As you are doing these, these three things where you're intubating, having bronchoscopy, vac ventilation, you ask for your chest X-ray, you ask for your labs, you ask for your cross and match, you ask for your IV access, and you try to correct any coagulopathy. Okay, as you're doing all of these, okay, once you get inside the airway, what are you going to see if there is massive hemoptysis? Clots, right? First thing that you'll see is a clot. What do? Aspirate. Most of the time, you will not be able to take it out because it's going to be bigger than your ET tube. Okay, so what would you do? Push. Exactly. Push it down. Okay, it doesn't matter. Get a lobe that can ventilate. Okay, push the clot down. If you cannot take it out, push it down. You want to create a right upper lobe or a right lower lobe that is ventilating. Okay, your bronch going down, okay, is creating a channel for air to get inside the lung. Okay, even if you push the clot down with you, it's good. That's fine. Once you get the ventilation, the patient is starting to have a little bit more oxygenation, more ventilation as you're suctioning and pushing, getting the clots out. Okay, you have to see, is the lobe that I'm in actively bleeding or not? If not, then it must be the other lobe. Go to it and do the same and locate where basically the patient is bleeding from. Once you locate which side it is, okay, then basically you do the basics of, the bad side down, right? And then you work on what? Blocking the bad side, right? So you need to isolate it, right? Then basically you have to clean the good side really good and then determine what is the etiology, okay? Whether if you can bronchoscopically, and if you cannot, what? Then basically it depends if the patient is, stable or not, right? So if you stabilize the patient, you do a CT scan, and that will help with embolization. If the patient is unstable, you talk to the radiologist about doing an arteriogram immediately, right, to do the embolization. And if that is not available, you call the surgeon. You tell him, I have a right lower lobe that is massively bleeding. This needs to come out. Of course, you will have some chest X-ray. I really never reached that where you need really just to take someone for surgery if you employ these things and you block the lung. So let's talk about how we what. Oh, by the way, if you don't identify a source, remember you're in the ICU. Both the alveolar spaces can bleed, right? Remember diffuse alveolar hemorrhage, especially if blood is coming from everywhere, right? Then the treatment would be totally different. Let's see. What did I get here?
So one of the fellow will be intubated, is that it?
Huh?
Intubate both of them.
Yes.
Yes, if you would like to learn more.
Oh, the nutrition
Yes.
before the law.
No, actually, Katie, she did not eat.
Yeah, I bet you.
Yeah, she's NPO. But you know what? Before we do this, let's talk about what I have here. So, pseudohemoptysis, you guys know what that is. It's just something coming from the other source. If someone has a massive hemoptysis and you go inside the lung and there is nothing in there, or just it's coming from somewhere else. That's not. But it's still, you have. If you have someone who is in distress, no matter where the hemoptysis or the blood is coming from, you still need to intubate and deal with him the same way. Uh, um, it is very hard for someone to have a massive hemoptysis with normal lungs, right? Chest X-ray or CT scan, it's almost impossible, right? So upper airways are usually nasal passages are where you get most of them. You have to consider, the Osler-Weber and all of these things that can cause nasal abnormalities and pharyngeal abnormalities. One one trick is that if you're suspecting um, 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 pseudohemoptysis from a nasal passage before you intubate the patient, is that if you make them lean forward, okay, if the blood stops draining and it's just start trickling from the nose, it's a nasal bleed. And trust me, nasal bleeds can be very, very, very bad. Upper GI can be really, really tricky. Sometimes the patients will vomit, coffee ground. Now it's almost impossible for you to know this is swallowed blood, this is nasal blood, or is it really upper GI blood? But it's of course always, suspicious when you see coffee ground that the source of the bleeding is an upper GI. But again, you should not take it, lightly. So multiple ways of achieving the blockage or the isolation in massive hemoptysis when we are dealing with bronchoscopy. So you can do endobronchial blockers, you can do Fogarty catheters, you can do double lumen tubes, you can do something called spigots, you can do stents, you can do glue. I personally prefer the blockers because this is the way that I was trained. Fogarty's can be inserted, but it's very difficult to guide the Fogarty catheter to where you want it, and it migrates a lot.
Yeah.
It's very hard to keep it in place. Double lumen tubes are things that you're going to need to ask the OR for. You don't have 15 minutes to call for the OR to get a double lumen tube. It needs experience in putting the double lumen tube, for example, intubating the right main, okay, with the double lumen tube is it's really difficult, and you will occlude the right upper lobe with it. Bronchoscopy with a large scope becomes almost impossible when you put a double lumen tube. You will lose all your suction power with the bronchoscopy. I really don't like it, but that's just my opinion. Spigots are usually not available. Glue needs time, and stents need time, to get it from endo or get it from somewhere. So wherever you go, always you should have something like this, okay? A blocker available to you, okay? Multiple forms of blockers, multiple sizes of blockers, okay? Be familiar with what your hospital has. I'm familiar with this because I have it, okay? So there is the Arndt, okay? This is the ARNDT, the Arndt Cook catheter. There are multiple of them. There's the Easy blocker, there is the Uni blocker. There's like multiple of them. This one is
That's the most common.
this is the most common, yeah. The Easy blocker, for example, it is something that you put, basically it's a Y shape, but it will go into basically the right and the left. So you can select to occlude whichever one you want. Okay, so it's beneficial. I've never used it.
I've never seen it.
This is the Univent blocker. This is what we have at St. Mary's, but we do not have the AT tube for it.
That's great.
But you can still use
Yeah, you
it.
can use
It is curved at the end. When you put it in, you can just rotate it right and left.
Do it for a few.
No, inside the tube.
Oh,
Yeah,
Yeah,
you
you
can
mean
rotate
you-
it right and left to guide it because it's curved at the end. It's like this. It's like about 60-degree curve at the end. You can put it in the right or in the left. So you don't need this tube. And this is the Arndt blocker, which is the most common. Okay. Remember, you have to fill it with saline, not with air. Okay. Multiple ways of putting the ET tube. I want you all to see this. This is a universal applicator. If you're using a large French blocker, you have to use a very large ET tube. And always remember, when you intubate with the biggest possible ET tube. In men, put a 9 if you can. In women, put 8 or 8.5. Okay. Classically, this hooks to the ventilator. Okay. This with the thread on it goes in here. Maybe.
The thread is open.
Huh?
Usually it comes like the thread. I thought it would be like more.
It's
close.
So you put it right here. This basically is to help you put the scope basically, through this hole.
Not you, but it's.
Yes. So basically you have to put your bronch inside this loop. There it is.
That's why.
All right. Yes. And then you basically unhook and tighten.
Do you see inside, guys?
So do you do this before you hook it to the tube or after?
No, 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 no.
You hook it
After.
to the tube after.
Yeah, we hook this to the tube.
Can you
This
open
is-
it again?
It's just because I'm.
So just show them the.
Yeah.
That's what it's similar to the DR one.
So now basically we can advance both together.
See what's happening?
And I can guide where I want to go with this. So basically I go to the left and push this on top of it, or go to the right and push this on top of it. Okay? So this is what most people would do. The problem with this approach is what? You are basically occluding most of your what? Airway. Yeah. And it will give you difficult, ventilation and difficult, suctioning, because you're going to be obliged, even with a number 8 tube, to use only the 4 millimeter thickness bronchoscope. So you can't use a therapeutic scope.
No, yeah.
Okay, when you do this. So what I do, which is not how it's recommended to be done by the company, I intubate like this. So I put this in here. Yes, and basically, you understand what I'm saying, right? So I put it here, tighten it around it, right? And intubate with this as a unit after this is tightened, okay? I'll have the anesthesiologist or someone just do a direct laryngoscopy for me. I'll see where the vocal cords are. I go in and intubate, and then after this is basically in place, okay, inside the tube, I basically move all of this as one unit with me and put this in the right or in the left with the ET tube in its place. This way, this will be outside of my ET tube. Okay, I guarantee I can get the 3.2 channel, bronchoscope inside the therapeutic channel. Okay, and aspirate or have suction power as much as I want. Okay.
Just the only difficulty in this way is like intubating the patient with all the blood and his
Yes.
hemoptysis. So you need help.
You need help.
In ICU, I mean,
Hmm?
probably in ICU, you don't have the bronchial blocker there.
No, it's on the shelf in the ICU.
Yeah.
Yes, it is on the shelf in the
And we
ICU.
have one in our room.
We're talking about St. Mary's, so they don't have that, what alternative?
They have a uni blocker. We were just talking about it. It's in the OR. It's not in the ICU there, but it's curved. Okay, it's blue colored. It's called uni blocker. You can put it inside the ET tube. Okay, and you can actually rotate it right and left under bronchoscopy guidance, and you insert it.
And so the way that you insert.
And they have
tube,
it has something like this similar to it. The benefit of this over that again is that when you put this in and it's already in the location, like for example, it's in the left right now, it's inflated, you can lock it here. That will stabilize it in
And
place.
usually know the numbers, where exactly. And
Okay, and you know exactly where it is. Now you can use this for, once you remove this, you can use this for CPAP, put epinephrine, drain if you want. You can hook this to this and basically drain blood out.
But I think if it's out, you cannot put it back again. This
Yes.
wire.
It's out,
It's
it's very hard to put it back up. So I made the mistake and took it out.
Yeah, I think it will not go.
So the name for that is endobronchial.
It will?
Yeah, you
I think it
can.
will not.
So the curved one, what do they call it? Endobronchial.
Uni blocker.
Uni blocker.
I've never seen it, but that's.
No,
Yes, I know.
one day they brought it for us because I asked for it before.
Oh,
Trump
and-
took the bill,
and-
just in case. They said this is all what we have.
And
So that they have this
yeah.
one.
Remember, it's whatever size you use, it's written on it exactly how much volume of fluid you have to put in it. I think this is the 7. I think you put in about 4 to 8 milliliters of saline in it.
The reason we
inflate it.
Put fluid instead of air is to give it some heaviness in the airway to stay there.
Can you compress fluids? Can you compress air? So if the patient moves, coughs, he will leak if it's air. If it's fluids, it's unlikely that it will be compressed. So a leak is unlikely. Remember, this is not just used for hemoptysis. This is used by surgeons to isolate the lung. Like if I'm doing a VATS and I want to do, for example, lobar resection, I can't put a double lumen. This is what they use, okay, to isolate the lung.
This other point to add on top of this, like if you are doing procedure in the future and you're by yourself and you know this procedure has a high risk of bleeding. So one of the most important thing that don't cut your ET tube. So like sometimes I'm doing EBIS or something, they cut the ET tube, or sometimes I cut the ET tube to have more manipulation of the procedure. But if you know this one is like high risk of bleeding, what will happen is like, because if you have bleeding the right side, I can just like push my tube, shove it in like the lung that I need to ventilate, and the other lung will be blocked. Is that right? But if it's cut, I cannot do that. I have to take this tube out and put another tube in. So you have to like put the expectation of like the lesion that you are dealing with. Is it like a lesion that has a high risk of bleeding? If it's you're unlucky, that's something.
Yeah. So this is kind of like a surgeon who likes double lumen tubes more than the endobronchial blockers. But you know, at the end, it will be basically your preference and how. So removal of clots, as we just you know said, use the larger scope. Always, if you go to any institution, always make sure that you have an XT160 or TX160 and an XT190. This is basically the best. These are the best scopes that you can use for um, suctioning of clots or suctioning of any material. You need a minimum of 7.5 AT tubes to handle these tubes.
The biggest in your work channel that we have is 2.8 here.
No, 3.2.
3.2, the therapeutic.
Yeah.
Do we have it here?
Yes.
3.2?
He
Yes.
does the stint through it, is that?
Yeah, yeah.
Oh,
Yeah.
okay.
We don't have the new one though. We don't have the XT190. We have the TX160, the old one, the very old one. But it's 3.2 channel. Another way of removing the clots, if you're not able to remove them with the channel, is basically to use the cryotherapy probe. Multiple sizes, of course. Always use the 1.7 millimeter. It's going to be much easier. In case you have just the 2 millimeter channel bronchoscope, always choose the 1.7. Basically, what you need to do basically is to freeze enough to form an icicle on the clot itself. Basically, once you see the icicle formed on the tip of the clot, you just pull the whole unit out. Okay, and trust me, you can basically remove entire bronchial tree casts with the cryo. Okay, you can remove an entire cast completely out with the cryo.
We had one that he has nasal bleed, but he has aerated all of that and clotted inside his lung. So it looks like this, like nasal, like a bad nasal bleed can block the whole.
Yeah, if you aspirate,
Yeah.
yes, absolutely. Now you have to pay attention that your probe is only laying on top of the clot, not touching the wall. If you pull, you're gonna pull the mucosa too, and you'll cause some more bleeding. And I have seen people also, because they can't see, they activate it, okay, and they actually freeze part of the ET tube too with them. So basically, they will pull the ET tube with them. Yes, with the inflated cuff through the vocal cords. Yeah, so you see the tube with the clot with everything in your hand. So this is just a general list of the etiologies of hemoptysis. There's remember the heart, of course, diffuse alveolar hemorrhage, bland hemorrhage. Remember the valvular issues. The most common um, causes of massive hemoptysis are bronchiectasis, okay, mycetomas. Worldwide, it's tuberculosis, okay, diffuse alveolar hemorrhage, okay, and vascular malformation. Lung cancer usually, I mean, it is part of course, the differential diagnosis, but I don't think that it usually causes massive hemoptysis. Of course, it can, but the most common, I would say, is having bronchiectasis, tuberculosis, mycetomas are the scariest hemoptysis that I've ever seen. And actually, I remember the worst cases were mycetomas and sarcoidosis.
Wow.
In the bronchial sarcoid or?
Mycetoma because of
Oh,
sarcoidosis.
because of that.
Yes, these have vessels that come from everywhere, everywhere. So definitive therapy for the massive hemoptysis, it's between the bronchial arterial embolization or surgery. Usually the most effective is acutely is the embolization. Okay, it's basically 90% effective. And if it is not effective, okay, it means that most likely the interventional radiologist missed something. Go back again, especially if the patient is stable. We're talking about a patient who is stable, bleeding is isolated, ventilating fine. Okay, do a BAE again. Okay, because most likely if they look for example, the subclavian or internal memory, they will find the collateral to that source of bleeding, and they can embolize it too. Surgery is reserved, of course, for patients who fail 2 or 3 BAEs, and for severe, uncontrolled, unstable patients who need to go emergently to the to control them to go to the OR. Mortality, of course, in these cases are extremely high. It ranges from 6 to 40%. Talking about a mortality rate of BAE of less than 1%. So much better, much safer, even if you try it twice. The fact that they failed once is not bad. That doesn't mean that they're bad people. It's very difficult. This is an algorithm. I like it. It's actually published. I don't know. I don't have the citation for this in there. It's actually a very nice article, review article. I'll send it to you. But this is how it's almost the same what we discussed about how we manage massive hemoptysis and life-threatening hemoptysis. The algorithm is very nice. I will keep it here for you. I'll send you the lecture anyways. And these are, of course, we'll move to the non-massive hemoptysis now, and these are the most common causes of non-massive hemoptysis. I think in our area here, bronchitis, pneumonia, infections are the most common. Second is probably second or third, they alternate lung cancer and pulmonary embolism. Okay. I haven't seen lots of mycetomas. I haven't seen lots of TB here. Bronchiectasis is not very common. We're not a large CF center, let's say, here to see lots of bronchiectasis with hemoptysis. I always shit my pants when I hear, or used to hear, cystic fibrosis with hemoptysis. Literally speaking, this is the scariest thing that you can ever have. And I've seen a great deal of cryptogenic hemoptysis. So regular with a smile hemoptysis, there is of course no regular hemoptysis. I call it the regular hemoptysis for the non-massive hemoptysis. Okay, so basically non-life-threatening. You still have to consider it an emergency unless it's cryptogenic, chronic, a known etiology that is recurrent. For example, if you have hemosiderosis, not everybody who has a scant amount of hemoptysis, okay, needs to be admitted to the hospital. These people who have cryptogenic hemoptysis, who've been fully investigated, have had it for years, you don't really need to admit them unless there is a sign of clots or instability. The things that you need to do, of course, the basic stuff, history, risk of TB, you have to calculate the risk of cancer. You need to know what is the risk of cancer, what is the risk of having bronchiectasis, cystic fibrosis, coagulopathy, quantify the hemoptysis. If it is significant and more than 100 mLs per 24 hours, this needs, to be managed and stopped, okay? Irrespective of what the etiology. Of course, an X-ray. And in most cases, right, you need to obtain a CT scan. Okay, especially if this is the first or the second episode of hemoptysis. There is no management of hemoptysis without CT scan, and it has to be a CT angio. It cannot be a CTPE protocol. It cannot be a CT without contrast. You want to identify the systemic vasculature. Okay, this will help the radiologist also choose where he would go for his what? BAE if
opinion, it's helping to identify whether there's bronchial, circulation
exactly.
causing the hemoptysis.
Leading to whatever abnormality you can detect. So the CT angio, you will get two things. You will get basically a PE study, because you will have complete coloration of the pulmonary artery, and you will have complete coloration of the systemic vasculature too. So if you see any abnormality like a mycetoma or bronchiectasis, okay, you can actually detect which vessels are enlarged and which bronchial arteries are enlarged. It will be guiding the interventional radiology to where he would embolize. Comparing CT scan with bronchoscopy, okay, in non-massive hemoptysis. Okay, very important to know this. Both are good in localizing, okay, the site of um, where the bleeding is coming from, which side it's coming from. But diagnosis-wise, okay, CT scan is way superior to bronchoscopy. Why? Because, as we said, pneumonia, bronchitis, lung cancer, deep, mycetomas, TB, you will not see this on bronchoscopy. You will see an endobronchial tumor, right?
If
You-
there's any.
If there is any,
Tell you.
exactly. So CT scan is way more helpful for the diagnosis, okay? Bronchoscopy comes as a second hand. If the CT scan is negative, okay, you do not know which side the bleeding is coming from, and you don't know why, then basically you would do the bronchoscopy. Or you would do the bronchoscopy if someone has a high risk of cancer, okay, and you do not find um, an etiology by CT scan, then you need to screen for small endobronchial tumors or small abnormalities to rule out cancer. By the end of the day, it remains an academic discussion, because if you find, for example, a cavity, okay, and that's the source of the bleeding, and you want to diagnose it, you're going to do a bronchoscopy. Okay? But you have to know that sometimes for patients who have the moderate hemoptysis, that I don't want to wait 5 days to do the bronchoscopy because the bronchoscopy suite doesn't have time. I want to stop the the bleeding today or tomorrow. Okay, it is okay to do only CT scan if you find a cavitary lesion. Okay, to stop the hemoptysis, you want to send him for BAE without a bronchoscopy. That is okay. You don't have to do a bronchoscopy to determine the etiology or the side of the bleeding. Okay, CT is usually enough. Uh, so conservative management, for people who have symptoms of bronchitis, infection, pneumonia, small PEs, all of these people can be treated conservatively without intervention, without BAE, and without any bronchoscopy to stop the bleeding. Still, BAE is the main modality that we treat even non-massive hemoptysis, that is clinically significant. Um, the only thing is that the recurrence rate for hemoptysis in 6 months is about 20% with BAE. Okay, surgical resection, if possible, or if indicated, has basically no recurrence rate whatsoever if they did a lobectomy or did a segmentectomy for whatever that's causing the hemoptysis. Of course, it varies depending if you want to send the patient, to surgery or not, depending on the etiology, right? If you find cancer and it's causing hemoptysis, it's better not to do BAE. It's better to go for surgery immediately, right? If you find a mycetoma or tuberculosis causing the hemoptysis, you're not going to send him for surgery immediately, right? You're going to do a BAE, then you're going to treat the TB or treat the infection and wait. So it depends on the clinical situation, but both ways are valid, right? This is a view of a bronchial artery angiogram. You see this right here? Do you know what this is?
The collateral.
Aorta.
Mm-mm. So if you occlude this, artery right here, the patient will be paralyzed. That's the anterior spinal artery. Exactly. This is one of the common complications. Yes, ischemic transverse myelitis is one of the most common, well, not the most common now, one of the common complications.
I think that's the CF. Instead, someone for embolization had significant hemoptysis from bronchitis for CF, and she couldn't move.
Yes, so they will get paralyzed. Now, now with super selective BAE right now, they can do microcatheters and bypass this area and go deeper beyond the bifurcation. But still, it is it is a common complication. Other complications, you can get systemic embolization from the materials that they use. This is, for example, a mycetoma that is basically coming from an intercostal artery, not from bronchial artery,
Yeah.
for example. The one that was before this right here is basically, this is the superior intercostal arteries. And look how the collaterals are all blushed coming from the superior intercostal artery. A bronchial artery is coming out of the superior intercostal artery. So it's very, very heterogeneous, very difficult. And this is, what is this? CT. You guys know what this is? Pretty sure that you, no. Bronchiectasis, yeah. Classic upper lobe bronchiectasis. What? What is it? CF. This is this is yeah, cystic fibrosis. So, yeah, you can see the enlarged bronchial arteries right here.
Like peribronchivascular consolidation.
And this is the bronchial artery,
Yeah, look
wow,
at this here.
look at how big is the bronchial artery, like on the other side.
Look at this. Anyways, quickly, because this is important, for the conservative management, if this is an option to do if someone has repeated hemoptysis or significant hemoptysis, but it's not massive, is to use tranexamic acid. You can use it orally or IV, but better to use it nebulized. Okay, randomized controlled trial and Japanese registry that is huge Japanese registry in the thousands actually. It lowers the time to hemoptysis by about 2 days, decreases length of stay, decreases the volume, and actually decreases mortality within one year. Both a small study and the registry. So so it's very very nice study. We don't use it here. Have you guys used it?
Yeah, last
Look.
month I have the yard physician do it for 1 day.
Good. So the dose is 500 milligrams Q8 hours for people who don't have, massive hemoptysis. Now, tranexamic acid also can be used endobronchially when you have a hemoptysis, like during a procedure, or if you're doing a bronch for a massive hemoptysis, you can actually try it endobronchially, 500 milligrams and 20 mLs, and you inject it inside the bronchus. And that can help also stop the bleeding. Tranexamic acid, yeah, good. There are lots of things that you can use endobronchial.
It's still like more evidence for cold saline, I think, first.
Yeah,
I mean, it's
Actually, you know what? No. The evidence for cold saline is actually much less than that in the tranexamic acid. So when I looked,
so you think it's underutilized?
yes, I think so. I really think it's not. It's not utilized as it should. I think that the cold saline, the evidence for it is to use about anywhere from 300 to 700 mLs. You have to use it 50 cc's Ellicots. This is how the studies were done. Okay, and at 4 cc's, sorry, at 4 degrees Celsius, cooled down to 4 degrees or less. And they had to use like about on average 500 mLs to stop bleeding. I know we use it. I use it a lot.
I thought there is another study like it's comparing like the endobronchial epi comparing to the cold saline, and the cold saline showed like better effect.
It's better than yes, but still,
But
yes,
still-
it is. But it is. They used huge amounts.
Yeah.
You're talking about 300, 400 mLs of cold saline, which is of course is associated with
And not like someone
hypoxia.
bring the bag of ice right now, but then
Put the
it's like
yeah.
it has been prepared.
Yes.
for-
So when you're doing a bronch,
Should be prepared, like if we
Yes.
anticipate maybe a case of like the tranexam, is it handy, like, because the cold saline,
You have to order it.
if they prepare it, epi is very easy, you can get it.
you have to order it from the pharmacy before the procedure.
So,
We
yeah.
got it pretty quick the other night with that hemoptysis. They
No,
brought it up.
In
within a
the
couple
yard, they
minutes.
get it the other day, the line.
Yeah, they can get it quickly. It's just a confusing.
But you have to
order.
continue it, of course, TID for about 5 days. The nebulized.
And the good thing, there is no high risk for
No,
venous thromboembolism.
no increased risk,
Yeah.
no, with it.
No increased risk compared to
No.
someone is not. No.
Remember when you're doing biopsy during the bronchoscopy, most people who develop bleeding are actually don't have high risk for bleeding. So they don't have pulmonary hypertension, they don't have coagulopathy. You've already corrected all of that. So if you're doing a biopsy, whether transbronchial or endobronchial, okay, always be ready for a possible bleed, meaning that always have the ice bedside, okay, before you start. And if you have epi, have it ready. I usually just make this cold saline ready. I do not, I do not have an epi ready to inject. Depend more on the cold saline. All the techniques, that we talked about can be used, inside the procedure. So there are multiple ways of dealing with active bleeding when you're doing a bronch for hemoptysis or procedural bleed. So you can use cold therapy. It is recommended by BTS, the British Thoracic Society, to use multiple aliquots of cold saline, but it's not based on any study. It was just expert opinion. The only two studies I found about the cold therapy, which is injecting the cold saline, which is large volumes of 4 Celsius normal saline. You can use vasoconstrictors like adrenaline, terlipressin, ornipressin. Okay, French love to use the ornipressin and terlipressin. I don't think that they're available for us. We have vasopressin if you want to use it. I've never used it in my life, but I mainly depend on adrenaline.
I think it's in the process for approval in the United States.
Yeah, but I don't think it's available right now.
Yeah, no, it's not.
Yeah. So thrombotic approach, you can use the tranexamic acid. There is fibrinogen and thrombin. There is oxidized cellulose that you can, which is a mesh that you can put inside the airway. I've never used any of these. There's mechanical approach, which you can put a stent to jail the bleeding side. You can put endobronchial blockers or spigots. This is a spigot. You don't want to know about it. It's only the French use it. The Tal only use it. I don't know who else uses it. We'll leave these to another day. How to use the APC and laser for. This is an algorithm I found to deal with hemoptysis, regular hemoptysis, which is basically what we discussed. Okay, that's it.
Yes.
We finished on time.
Pulmonary hypertension at risk of,